not as interested in having a group of residents that perhaps look different than they look. So that wasn't something that I expected. And so what we've done is we do have our monthly diversity and inclusion meeting, and really the point of the effort initially was to enhance our recruitment and then subsequently support our trainees. The thing that happened is that it was on a Friday afternoon, and one of our trainees at that time was Muslim, and a parent refused to allow her to care for her child. And it was, of course, Friday at 5 o'clock when there weren't as many folks in the building. But it turned out that the Children's has a code of conduct, which was, of course, unbeknownst to any faculty member in the building. But the administrators and the nurses were very well aware that we don't discriminate. We don't discriminate based on race, ethnicity, religious background, what have you, and in employment and interactions with each other. And so the nurse administrator who was available at that time, of course, it was very upsetting to the resident, who was a very good physician and was completely had no idea that anyone would refuse to allow her to care for their child. Basically, they explained to the parent that, we don't allow this behavior. And so, subsequently, we recognized as a residency training program that we were completely unprepared to respond to that type of a response from a family. And so we subsequently were very deliberate about how we educated and empowered our residents to not only continue to engage with a family when they experience these types of conflict or disagreements, but also to support their colleagues who may experience these types of interactions. And so the first thing that we did was we sort of took a poll to see, how prevalent is this in our residency training program? And it turned out that about a third of our residents had been, the victims of some sort of comments, either from patients or families or other staff members, because of, race, gender, age, ethnic background, what have you. And over 60% of our residents had witnessed someone being the victim of this. So clearly we had a significant problem. We have a communication course each year where we allow residents to practice challenging conversations. And the case that we permit them to practice is different depending on what your level of training is. And the first year case is speaking with a family about an unexpected diagnosis. The second year case is being in the hospital at the bedside, talking with a family, with a medical student who perhaps is overly eager and not attending to people's emotions and helping to guide that learner. And then the third year case is practicing how to disclose a medical error. And so we decided in our diversity and inclusion committee to change the second year case such that the conversation at the bedside included the parent making a comment about a member of the care team and how they didn't want that person to participate in the care of the child. And then that way the residents would at least have the opportunity to practice having that conversation. They could choose to have that conversation about one of their colleagues that wasn't present in the room. So in other words, a patient is admitted overnight and there's an African-American resident who cares for them, and the next morning the mother says, that's fine, but I don't want that person coming back to take care of my child, so that you could then have the conversation with the parent about the fact that this is a trusted member of our healthcare team, we don't discriminate here, she will be back this evening, what have you. Or we did that for a year, and then the resident said, well, that's not real enough. I want someone to say something to me about the fact that they don't want me to take care of their child. So it became pretty much of a, you can design your own experience at the bedside, whatever it is you want to practice we have standardized parents who are actors and they're trained on how to do this. So it's a very wonderful learning opportunity for the residents. But it is truly unfortunate for me to recognize that these efforts that I was making to diversify the residents then sort of set them up for these negative experiences from patients and families who might not be as welcoming a community as our training program was. The other issue that we have also had to intercede with is some staff members were also not as welcoming to people with different skin color or accents or what have you, and made very unwelcoming comments like, why are you here training here in Pittsburgh? So those are the kind of things that are happening at Children's. There's a lot of great things that happen at Children's, but there's still a lot of work that needs to be done to help our healthcare system be more inclusive, not only of patients and families, but also of providers.
So tonight we will have this kind of a practice.
So we can. I'm not a trained actress, but I can do my best.
What would be the response, basically, to I don't know if there's an ideal response.
So that's a really great question. So the most important part of the experience is to feel the experience, right? For you and I to be in a room together and for you to say something to me about, for example, in my experience as a doctor, it is not uncommon for a parent or a grandparent to ask me, especially maybe 30 years ago, when will the doctor be here? When the conversation started, hi, I'm Dr. Dewar. So then I, kind of have to go back and remind them that I am, in fact, a doctor, and it's kind of hard sometimes for people to recognize that. So, I mean, that's a gender or an age discrimination that I've experienced. I think that's something that nobody ever prepared me for, and it's just sort of helpful to think about how you're going to manage that. I think in that scenario, we decide, the resident decides what the experiences they want to have. Sometimes it doesn't go well. Sometimes they get angry because the comments are so ridiculously offensive. The great thing about the training is you can rewind it and say, okay, that didn't go very well. Let me try that again. Or let your colleagues give you some suggestions on how you might respond. So it's a nice experience because you get to feel what it feels like. You have some colleagues with you. There's 4 or 5 residents that do it, each take a turn. And then you get to watch other people practice different ways to say it. So I have to tell you, I've seen people do it any number of ways. None of them are right, none of them are, some go better than others, but the truth is at least you practice sharing that. The goal is you and I remain on the same care team. We're focused on the care of your child, as opposed to me, slamming something on the floor and walking out, and that doesn't help us, work together. So there's really no right answer. It's just a matter of practicing it.
It's a question of system. One of my friends went to the hospital in emergency with this child burned her, and she was 1 year old. But the hospital refused to treat the injury because they wanted to do other screening, like how it was burned, whether the child was ambushed or something, and because of that, it took like 2 hours, and finally she was not to get there, and she had to go to Mercy Hospital because there was no bird doctor. So how does that work? And he was really angry, and I was like, maybe there's some system that we don't know. We have to ask. That's what I said. So if you could just do that.
That is one thing that we don't have at Children's Hospital Pittsburgh, and that is good burn care. The issue of investigating what might be non-accidental injury is something that all pediatricians are wary of, just to be sure that kids are in a safe environment. As a parent, I would imagine that would be a very threatening and upsetting experience.
Yeah, he was actually very much insisting that first treat my child.
Yes.
Yeah. So, and after that, I'm ready to present.
Right, of course.
So that's what he said.
Of course. Yes.
I just had a question. The training was just for physicians that you described?
This training is actually just for resident physicians. So these are only physicians in the residency program. We had talked about expanding it to other physicians like faculty and other people who work in the hospital.
Okay.
And, you know, how can we do better talking to each other?
I like that because I'm a part of diversity and inclusion, and one of the things that over time, the last, I would say, 10 years in the business, is a lot of this training modules. Well, what you're describing is a conversation that people are having, and sometimes it's unpleasant, but that's the conversation we need to have to really get to the crux of what may be an issue, or help people to see that, you know, something you said may not have sounded right to me, or it didn't feel good to me, and now you get to experience that. So how does that feel? You know, that type of.
Right, and those conversations don't happen too much, right? There are things that happen between people, and people, for whatever reason, don't feel empowered to speak up, or feel like, well, maybe it's just me, and that thing really wasn't that terrible. But, you know, we just don't have those conversations, and it makes me sad to know that continues to happen.
But what's the name of that? Do you know the name of the training program? What's the
No, it's just, it's a communication course. So we are very fortunate at Children's because at the University of Pittsburgh School of Medicine, they have, they do a lot of simulation training for medical students. So, you know, to teach a medical student to walk into a room,
Okay.
first off, knock, wash your hands, introduce yourself, ask the patient how they would like to be, you know, those types of things. So we do that first year, second year, and we're fortunate to be able to use those simulated patients and parents. Yeah, we have a great resource here at the medical school.